I'll just start with one. Can you expand a bit more on this business of asset rather than need, Donna? Because I think it, for me anyway, it feels like it's absolutely at the heart of how you shift the approach if you're going to make ICSs do something. So would you mind just doing a bit more about that for us?
Yes, no problem. So I think there are two ways of looking at an issue, aren't there? I think there's an asset-based approach, a strength, trying to find the strengths in any situation or in any problem or in any individual's presenting problem or in any family or any aspect of life. And then there's a deficit-based model. So, the asset-based model looks for the things you can build on, the positive things, the things that people like to do, the things that they're good at, the things that they're interested in. And a deficit-based model starts with a punishing type regime. It starts with defining a problem. It starts with blaming people. It starts with putting people into little boxes of need. So somebody is, I'm sure you've heard the term NEET, not in employment, education or training. Somebody is a bed blocker. These are terms that are not great. Somebody is deprived. Somebody is a frequent flyer. These are not things that you want to be. Somebody is a troubled family. I don't think anybody would want to see themselves as being part of a troubled family. We used to call it confident families in Wigan. So we turned everything on its head. Again, I'll give you a very practical example of some of the things we did around prevention. We had a young man repeatedly in and out of youth custody, constantly, in trouble, stealing things, really, really bad issues at home, serious problems with the parenting he was getting, and he had no self-esteem or confidence. So in the integrated place-based team, the police officer who was constantly getting him at the weekend and speaking to him, and then he would re-offend the next weekend, said, let's have a different kind of conversation about what's going on here. What do you like doing? What really do you like? And he loved fishing. And he said, right, don't do anything to break any of the rules that we agree in between us, and we'll go fishing. I will take you fishing next week. He didn't have anybody else. He didn't have a friendship group. He was being bullied at school. And it's that kind of different way of thinking about an issue and a problem and incentivising people. I know in a hospice setting that's what you all do, I'm sure, every day.
Great, thank you. I'm just waiting a few more questions to come rolling in. Do you mind if I just give an example of something we did? We gave someone a personal budget and they bought a shed. And that might seem like a weird thing, but actually the issue was this guy had autism, and he used to get very agitated and had frequent A&E attendances because he lived in quite a crowded household and he couldn't get any space. So we gave the family a personal budget. He purchased a shed, and when it was all getting too much, he just went to his shed, which was his space, and nobody else had a key. And his A&E attendances just went from like every week to never.
Exactly. And that's brilliant.
But it also, though, there's a kind of question that's implied in that, which is, how do you get the flexibility to start moving the money around to where it's needed rather than where it is? How do you start to broker that, do you think, Donna? How do you make that happen?
I think this is where we need courageous CCGs and courageous CCG leadership, because that's where and obviously CCGs are now going to be part of ICSs, and we're moving to a co-creation model. So I think we've got to have, brave finance people who get this, who can look at a whole model of, those interconnections between demand. So we're lucky in Bolton that we have got someone like that, and so for example, we've funded social care in Bolton NHS Foundation Trust because we see that as being essential to our success. We funded aspects of public health. We put money into health improvement practitioners within GP practices to bring people in for screening before they're ill. And I think that's, thinking about the prevention agenda, it should be of massive interest to all finance people. Thinking about, £1 spent, as Michael Marmot says, £1 spent in the first 1,000 days is worth £1 million later on, having to pick it up later on when people have started, those first 1,000 days, those last 1,000 days, taking some case studies from there, I think, and, really thinking about a different funding model, different pathways. There's got to be a different way of doing it.
Fantastic, thank you. Some specific questions coming in about hospices. I think perhaps the first one is to ask is how would we, it says you, but I think we is probably the right way to put it. How would we sell the value of hospices to these new 42 integrated care systems? What is it that we can take to them that makes them understand how special we are and what our place could be?
I think it's about taking those last 1,000 days of life and showing in a case study the dysfunctionality of our current system, because we all know, don't we, from personal experience, just how fractured and broken it is. Not from the hospice's point of view. I think as soon as a hospice gets involved, it improves massively in my personal experience. But up until that point, it's very fractured between the NHS and social care. There's different perspective. I always tell my story of my poor mum, sadly no longer with us, but on the day she wanted to die at home, on the day she was discharged from hospital, 22 different bits of the NHS and social care came up her drive, all in the wrong order, none of them knowing much about her or her wishes, and none of them really interested in that either, or the family support or the friendship support she had around her. So, I think explaining that you as a movement you've got that human connection, you've got that, you can straddle social care in the NHS in a way that I don't think any other organisation can. So I think that's the unique offer that you have. And I think you could actually save people money. I think you could present a more joined up and human model of integration for end of life and really put love into an ICS. The final act of love is dying well, isn't it? And I think that's really presenting that as a strong selling point for you. You shouldn't need to have to do it. People should know, but not everyone does.
Okay, thank you. So I'm wrapping a couple of questions together here. I think that I've got on the screen. Learning from what you did, and no doubt the resistance that you will have encountered, what could we do to help sell this model to the broader public sector, the broader public service?
I would start with quality. I'd start with the quality of what you do, and I would talk about, and I would present some case studies. I'm sure you've already done this, of without hospice support, a person without hospice support, how they have to navigate everything themselves, how it's not connected, how it's a tragic failure of public service, and you can see it. I know so many members of my family and members of other people I know who are just at their wits' end with a broken system, trying to support their loved ones. And I would show that in its, day 1, day 2, day 3. I'd show the current reality. I'm not sure everyone, unless you personally experienced it, knows how bad it is and how much worse it is now with the workforce crisis that we face. And then I think I'd paint a picture of a brave new world of hospices in the heart of the community and what good could look like. That's how I would get it across. I think it's, there is another way. And I think people think a hospice is a building rather than a different way of working. And I think that's what you've got to get across. If I can help in any way, I will. I think it's so important.
Thank you. Can I just switch to tackle a question here, which I think is quite an interesting. I think it's an interesting question anyway. It's kind of fairly easy, I think, for us to see how a properly supported and funded and integrated voluntary system gets in with the public service. Is there a place for the private sector in integrated care systems? I know there's quite a lot of political debate about that, and I understand there's going to be whatever the word is, an amendment to the Act that means that private sector organisations will not be able to sit on integrated care boards. But is there a place for private partnerships in all of this, do you think?
I think the private sector has got to step up. I think there's a role for them as as major organisations in a place. So, for example, not so much anchor institutions, that's more public organisations, isn't it? But to demonstrate their social impact, I think, and some of them have, haven't they, through COVID, I think it's really important that private organisations look, and some of them did provide support, but I think ICSs, I don't think they should be on personal view on ICSs. I think there's a conflict there that's just too strong. Mm-hmm. But I do think they should be looking to, you know, employ local people, give away support, whatever they do. So, for example, in Wigan we worked in partnership with Heinz. So every single tin of beans you've probably ever eaten in your life was made in Wigan. And we had a great food poverty project with them. So, you know, I think there is a role for the private sector, but I don't think it's on decision making around the allocation of public funding. Just a personal view.
Okay, thank you. So I think implied in something you said towards the end of that answer, that also is one of the questions I've got here. How did you manage to effect change so quickly? How did you not just get sucked up into the Kafkaesque bureaucratic nightmare that most of us live in eternal Zoom meetings where nothing happens? How'd you cut the crap, Donna? How do you get through it?
Yeah. I know, I like that, and I pride myself on being being really into cutting through the crap. I think I always apply my mum test, you know. So what difference would this make to my mum? You know, my mum used to pay a lot of council tax, and I used to drive me around the bend when we had interminable meetings about nothing and agreed to do nothing. You know, and again, I'm a member of a few partnerships, not my own trust now, but I get so frustrated by it's almost like they go through one meeting in order to get to another, and they obsess about governance structures, who's on which bloody committee, rather than what they're actually going to do. So I think really being that kind of grit in the machine is what a hospice could do in an ICS, is to say, so what difference is this going to make to the citizen? And I always keep asking that question. We used to have in the Greater Manchester Health and Care Partnership. I don't know if there's anybody here from GM today, but we had a guy who was the leader of one of the local CCGs, who would have Anthony Hassel, Salford CCG. He's now moved on to a regional role. He would always ask the Joan question in any of these great big meetings with Sir this and Lord that present. You know, so what would happen to Joan living in Pendleton in Salford under this plan? What difference would it make to Joan? And I think that's a really good way of cutting through the crap.
Yeah, absolutely. It was Ethel in Birmingham rather than Joe, but it was the same thing. What difference would it, this conversation? It was STPs and ICSs. What difference would it make? And I think the best answer I ever heard or one of the ways of testing that would be if we got to a place where you only had to give your information once, would be a really good example of where we got some, you know, proper integration going and working in the system. You did quite a lot in terms of what you did in Wigan, in terms of involving local people. Are there any techniques or tips or approaches that you would suggest that we could use for getting that community engagement?
I think the main thing is just going out there, putting yourself out there and listening in different ways, and not assuming that. I think very often organisations consult on something they've already decided they're going to do. So they'll go out there and say, what do you think of this? But they won't say, have you thought of anything else that we could be doing? So I think start with a blank sheet, start with humility. Encourage the voices that are the quieter ones to speak. So, you know, Tracy talked earlier on about racial equality within the hospice movement and how, you know, I do think there is an issue there, and I think it's important that you reach out to black and minority ethnic communities even more because of that factor, because of that perhaps hesitancy to think that hospices are for them. I think it's important that you encourage everyone. So it's not just a one-off exercise. Everyone understands how to deeply listen. And again, as I say, we used an anthropologist to help us retrain our brains, because we have a neural synapse, don't we? I'm sure the medics know more about it than me, but it helps us to filter out the things that we don't want to hear and focus on the things that confirm our assumptions that we already had about a person or about a neighbourhood and what they want. So I think we've got to try to deprogram that, really listen, and then do something about it. Rather than just listening and going back and doing nothing about it, we've got to actually change as organisations based on what we've heard.
That's quite a powerful thing to say, to retrain our brains. How did you do that?
It's you got to meet him. Actually, he'd be a really good speaker for one of your events. His name is Dr. Robin Farr, and he's a freelance anthropologist, but he's great. And so it's ethnographic techniques. We did a basic course in ethnographic techniques, which is basically trying to just rub out the assumptions that you've got and to really deeply listen. And every social worker, every GP, everyone even emptying the bins was trained in ethnographic techniques, in how to spot signs and signs of your own prejudice as well, that everyone brings to every conversation because it's just in you.
Do you know, there aren't many people who reduce me to silent awe, but you're one of them. I have to say, the people who enter the bins are trained to death. I mean, who else could even think to say that? There's an interesting question about the balance between data and stories. What's the place of, do you think, either or both of those in trying to understand this and affect change?
I think we've got to have both, really, because I think if you just have data, it's very cold and clinical. And if you just have stories, it can be at times a bit wishy-washy and unfocused, and it depends who's got the best story. So I think a blend of the two is where the magic happens. So I do love data because it has no ego. And often in an ICS, it's the person with the biggest ego and the loudest voice who gets the say on what happens, or the biggest budget. And that's not always the best way to invest or to do good on a particular course of action. The good thing about data is it's quite clinical and it shows you where you've got a problem. So I mentioned before, we have an issue in a part of Bolton called BL3, which is a postcode where we have a lot of our health inequality. And yet we weren't doing anything different in BL3 as a foundation trust. When we mapped it out, we had less doctors in BL3, we had less community organisations, and we had less support going into BL3. So as a town, as a place, what we are starting to do is to really think through the integrated care partnership, what support do we put in place in BL3, working with the local communities. We had a really high incidence of stillborn babies, and we'd really underestimated, this is where the anthropology comes in, the cultural issues that were going on in that community, particularly amongst Somalian women who had a cultural kind of tradition of not going, it being seen as bad luck going to the doctor before 3 months of pregnancy. And consequently, health issues weren't being picked up. So I think you've got to understand, so that's a combination of data and story. You know, the data, you can just look at it and think, oh, that's unusual, that's all in that spot. But then it takes the going out and listening and having those ethnographic conversations with people and saying, well, why? And it's the culture. There's cultural stuff going on too. So I think the two blended together is the right solution, definitely.
Yeah, there's that sort of, there's always that temptation to listen to the loudest voice or to look at the biggest, shiniest thing, isn't there? But we know that, for instance, in the healthcare system, that the NHS interacts with 1 million people every 18 hours, and 90% of that's in the community. But we never give as much attention to what's happening in primary care. And as you say, if you start to look at the differences in the pattern, for instance, of primary care, and look at referral patterns and so on, you begin to see very obviously that there are whole groups of people who are not getting access to what they need because, I know I said need rather than asset, but they're not getting access to that because they're just not being identified. The system doesn't operate in a way to bring them forward.
Absolutely, and yet we're interacting with them every day, multiple times a day, but not connecting the information and the knowledge that we have. Michael Marmot came to Greater Manchester a few months back and did a fantastic report commissioned by the Health and Care Partnership on Build Back Fairer, and he said you've got lots of big shiny new hospitals, loads of them, but you've got some of the poorest health outcomes in the whole of the UK. So for me, it's not about more beds. For me, it's about we've got in Bolton at the moment, we've got 3 full wards full of people who can't access any other form of support, and they've got no reason to be there. It's not a great place for them to be. They're safe, but they should be in a better supported environment. But because of the workforce crisis in social care and the fact that Bolton Council's had to make 39 million cuts in 1 year, this is the situation we face. So we can't do it as individual sectors. We've got to do it together around a person, a family, and a place.
Okay, thank you. I'm trying to pick up the most popular questions, and they're sort of the way the slide works is a bit tricky to find them. But there's one here that a bit cheeky, but I'll ask you. What assumptions would you challenge or reframe in hospice care?
Oh, that's a good one. I think it is this perception that it's a building. And that's the I'll be honest, that's what I had, because my granddad died in our local hospice, and he died in the building. I'd just got a view that it was the building, but it's not. It's a whole network of support out there in the local community. The volunteering aspect, the connection to, the locality that they're based within, the fact that they're a community resource. I think that's, and I'm sure that's already part of your plans, but I think that's the most misunderstood bit of the role of a hospice in an ICS.
Okay, thank you. There's an interesting question here. How would we convince an ICS of the value of the voluntary system when they think they've done their bit because they've got one Ned on the board?
That's very true.
That's a cheeky question, isn't it? I like the cheeky ones.
It's very true. You're absolutely right. And it's something that I've really pushed within our board. It's that one Ned cannot speak for a whole sector. So again, we need to have all of the design of our services needs to be based on hearing the voices of people with lived experience and the community organisations who support them. They need to be actively involved in redesigning those services and those pathways. So again, through the new local work that we do, we support around 70 organisations, mainly councils, who through a network of how, trying to learn how we can work differently with the community and voluntary sector and unleash community power. We call it the community paradigm. And what we see is people very often at kind of frontline or middle management role really struggling to get leaders to see the value of the community and voluntary sector. So, I think we've got to get our staff to understand and to reach out, rather than it just being the Ned on their own, bless them, or the board, or the senior management team. It's got to be every single person who works in public services needs to understand the power of the community and voluntary sector. And, they are the assets in a place, aren't they? Why we had no money in Wigan, we've got no money in Bolton either, but what we have got is an amazing network of community and voluntary groups, an amazing network of citizens. Why would you not tap into that? You must be mad if you don't tap into that and that strength of a people in a place working together and that energy they've got.
Okay, so last question, Donna. Several people have asked it, or they've liked it, so I have to ask it, though. I think it's an even cheekier question. So, did it work in Wigan? Are things better now?
Yeah, obviously I retired a couple of years ago now, but I think very often with strategies is that they only last as long as the chief exec or the leader. And then when the leader or the chief exec's gone, they just fizzle out. And I know that was an issue in Birmingham with the kind of high turnover of chief execs in the council. So I think it's important that a plan is developed, as I said before, a really simple and clear story of place and a plan for a place that outlives whoever happens to be the leader or chief exec. It's about the people. So I think that is the starting point. And the fact that it's still going, I think, is good, because people really did believe in it. Residents really believed in it. We had a 59% increase in overall resident satisfaction with the way the council does things, the old Murray indicator, after 10 years of funding cuts, which was quite unusual. But the main thing for me was life expectancy. So our main driver behind doing everything was increasing that healthy life expectancy. So the number of years of good life, of healthy life that people had, and it was 48 for men and 50 for women at one point. So in the most deprived wards. So that's not life expectancy, but years of healthy life. And we wanted to focus on that. We managed to add an additional 7 years in the most deprived wards to healthy life expectancy, and we reduced the gap hugely. So that was through mainly the prevention approach and focusing on physical activity. We funded something called Wigan Warblers, which was a singing group. This is one of the 500 projects to increase, because COPD was quite prevalent in in the borough because of the mining past. So we funded singing groups, we funded rugby memories, which was around dementia support. We handed over swimming pools, parks, community centres, a community farm for a drug rehabilitation project. So it was quite different. And I had to get, the whole organisation, the politicians and the treasurer on board with having the courage to back a different model. But, I think it's a model that works, and it could work in anywhere, I think.
That's great. Donna, can I thank you so much for your for facing all those questions and for your presentation this morning from us all here in Liverpool and beyond. Thank you.
Oh, no problem, Paul. Thank you. It's lovely to see you.